I'd like to thank our sponsors, Maxwell Tech, Steno Health, and Levo. Okay. All right. Welcome to the first podcast of the last visit, first visitor, David Curtis.
That's right. Right.
David Curtis is a dear friend of mine. We've known each other since I looked it up this morning, David. You guys were live on Homecare Homebase at the same time I started at Homecare Homebase in 2005.
August of 2005. I can remember downloading Point Care to a Palm Pilot
Yep.
or some device like that.
Yeah, it was called an unpack back then, but yeah, that was back a long time ago. So we've known each other since 2005. We've been partners in multiple businesses. We've worked together at multiple companies. So thank you so much for being the first guest.
My
we're
pleasure.
super excited.
My pleasure. I've always wanted to lead off, so I finally get to do it.
First time. Well, to get started here, we kind of talked a little bit about where we met, and I think you were the COO back at Graham, but give us the story of kind of your career. And I know you went to Princeton. I know you were a rower back then. And give me the story. Tell the audience who you are.
Yeah. So David Curtis, born and raised in Michigan, now live in Nashville, thanks to my wife. We've been married 19 years next month. We have 4 kids from 16 to 7 years old. We got married later in life, had all our kids in our 40s. You know, I grew up with 2 entrepreneurs. My dad was a solo practitioner physician. And my mother had a very successful ad agency. So I had a sort of a kitchen table education around people who kind of sign their own paycheck. And I always aspired to that. I had a business in college delivering newspapers throughout the Princeton community where, I did 100,000 in revenue and put 20 grand in my pocket 35 years ago. So paid for a lot of pizza and my friend's pizza. Ultimately I knew I wanted to work for myself, but I took a circuitous path, working in sales after college, then going to business school, then working in management consulting, but then actually through a client of my mother's, got introduced to a home health agency in Michigan and got hired by them to turn it around. It was $2 million in debt and losing money. This was a home health agency. And worked with the owner for 6 months and helped her turn it around, made it profitable, got her back in good graces with the bank. I'm like, hey, this is interesting, this home health business. Now, if there's only some good software to run it, because I had experience leveraging technology to help businesses run better. And this was 2005. And then I ran the Detroit Free Press Marathon in 2004 and met the owners of residential at the finish line, coincidentally. Got introduced to them by a relative. And they were like, yeah, we're wanting to put a budget together. We're wanting to maybe pick out a piece of software to run our business. And so they hired me to help them with all that. And I got it down to 2 software vendors, actually 3, but 2 was HealthWise and Homecare Homebase. And I liked them because they had workflow. And long story short, picked Homecare Homebase. And then as we're getting ready to implement Homecare Homebase, the owners of that business came to me and they like, you know what? We don't really want to be in this business anymore. There's only 2 of us that work full time in it. So if you could go raise the money, we'll sell it to you. So that was in May of 2005. I and some partners bought residential. And then August of 2005, we implemented Homecare Homebase. I remember it was the office was on 8 Mile. It had 150 patients. It had maybe 30 employees, all on paper when we bought it. And I remember we owned the business, closed on the business, May 26, 2005. And I remember sitting in the office by myself, like, where are we going to go get nurses? I just got to go get nurses. So long story short, right, that business doubled every year for probably 3 years, Tom. And Homecare Homebase was a key to that and just managing all that growth and staying compliant. And that's where I met you. And I remember just wanting to be part of something. I remember walking into residential saying, I want to be here for a while. And I want to, work with a team and do something that, we feel good about, right? As a team building together. And this past May was 20 years. And I still, what we do in healthcare has diversified from home health, but residential is still, I would say, my full-time job. And today it's, home health. We do home health and hospice. It's probably over 500 million of revenue. We're number 1 in Michigan and Illinois and Pennsylvania. I think we're great at partnering with health systems, and I love it. What I love most about it is I love just providing a great service, a valuable service, And then the team that I get to work with every day, I've worked with for 15, 20 years, right? Some of the first people I ever worked with, I still work with today. And so just having that history with a team, and we've grown up together, in a lot of ways. And so it's who you work with that makes the work fun.
Yeah,
And I,
it's interesting. That's
so
super interesting. How did you get them to stay that long? I mean, there's such high turnover in this business.
yeah,
There's so many things that are challenging in this business, and everybody says they're high turnover. But to get someone to stay somewhere for 15 years, I'm sure they
yeah,
changed jobs inside the
no,
organization.
no,
But
yeah.
what was the key?
Well, a couple things. I would say uh, growth. The agenda has always been growth, right? Because with growth comes more opportunity. And if you look at the leaders in my organization, are right, they didn't start there. They started off in the front line. And I think those are the most credible leaders, those who've been on the front lines doing the actual work, right? So I'd say growth creates opportunity and new challenges. And then then the other thing I would say is we're always challenging ourselves to make sure, like, I'm paranoid somebody's doing it better, right? So I'm always like, okay, what do I need to learn from somebody else to improve? And so we've always been sort of first to try new things, which is, I think, how you and I become friends, right? Because you're always selling new things, but you understand the business very well. You understand just how to run a great home health and hospice business, and so I think challenging our team to evolve and get better is I think is why people find the work interesting.
That's right. That's right. There's a restaurant in Minnesota that I attended one time, and the bartender behind the bar who was making my martini had been there for he'd been there for 42 years doing the exact
Well,
same job as a bartender. And I'm like,
yeah,
all right, what's going on here? And then he said, I'm not even the most senior person here. There's a lady in the back, her and her husband. The husband cuts the steaks and she's a waitress and she's been here
yeah,
51 years. I'm like, all right,
well,
how do you get someone to be in a restaurant for 51 years? Like, I want to learn from that person because they're doing something culturally right. They've never had a, collision. And I mean, they make good money, but I mean, Big John's his name, and Big John's been there for that long doing bartending. And you're like, wow, that's amazing.
yeah.
So let's talk about the tools a little bit. So it's always fun. AI is coming up. I know you guys introduced Levo into your business a little bit. What's positive about AI? What scares you about AI? Those kind of things.
Well, I want to address that, but I think just another thing around leadership and getting people to stay, whether it's at a bar for 40 plus years or at a home health agency for 20, is I think as the leader, and I know you're this way too, Tom, right? You have to be engaged in the work too. You have to be plugged into the details of what's happening on a day-to-day basis. You can't be so far removed that uh, one, you don't add value, and two, you can't be helpful. And so from the very beginning, right, every patient who's been admitted to our home health business gets my phone number, right? That's still in the starter care packet today because we all want great service. And if it's not going well, I want to be able to talk to somebody who can make a difference and solve my problem. And so I just think as a leader, we can't be so detached from the day to day that the team doesn't feel like we're there for them. But
So
as it
important.
relates to technology or AI, actually, I think you were the first guy who maybe a few years ago was like, "Hey, have you heard about this Chat GPT thing?" I mean, I can remember I was sitting on the couch in my office, you and I were talking about something else. I'm like, "Yeah, I kind of have, but I haven't really used it." And I think as I was talking to you, I downloaded Chat GPT, and that was sort of 1.0. We've been talking to some of the providers in our space who are doing the generative AI around documentation. Look, we've got to make this Oasis data set and the start of care visit easier for our field staff, and I think AI can help with that. So I'm always looking for sort of the next piece of technology that can help us. Um, and it's AI is certainly the topic du jour. We're I've also sort of leaned into some other ways of saving money and actually think improving cycle times and quality through moving some of our work offshore, which isn't necessary technology, but we're always challenging ourselves to figure out how to stay ahead of Medicare, right? As it relates to cost reductions and regulatory burden. Sometimes we've swung and missed, but oftentimes, we've piloted it, tweaked it, and then figured out how to make it work for us.
Yeah, I think it's really interesting when you start talking about you've adopted. I mean, I know you guys are a Pulse customer from Metalogics. You're a Muse customer. You were one of the first Muse customers out there, and
Yep.
thank you for that.
Yep.
We were the first to do AI. We really to take large language models as well as predictive technology and compare. And so you guys jumped on that, and
Yeah.
and you've been very, very successful at it. I mean, I know I've been on a bunch of calls with you when you were using the Pulse Episodes
Yeah.
product and
Yeah.
increasing research, decreasing lupus. Tell me about, your team seems to over adopt, meaning they're better adopters than everybody else. Why is that?
Well, I think that so we were the first ones to implement Homecare Homebase, right, in Michigan. In fact, I bought Homecare Homebase from April's partner, right? I didn't know who April Anthony was till I already implemented the software. She called for a collections call. She's like, "You haven't paid your maintenance fee." I'm like, "Well, why should I pay you all my maintenance up front? Aren't I going to be using this software over the course of 12 months?" And of course, April was a tough negotiator, and we worked something out. But we were the first to adopt Homecare Homebase. We're the first to actually not only implement Salesforce, but integrate Salesforce with Homecare Homebase. And so I just think we've always had this mindset of scanning the landscape for technology solutions that can help us. And that's just our culture, right? And so, I think our team has recognizes that we're gonna jump in first or early, and we know it's not gonna we're not gonna sort of stick to dismount every time, but we're gonna work at it, and we know as a team that if we work at it, some of the software will stick and make us faster, better, cheaper, and some of the time it won't, but that's okay. We'll learn from it. And so I just think we all have this mindset of scanning not just for technology, but just for better ways of recruiting, better ways of training, better ways of just the blocking and tackling of home health. And you are right. We were the first paying customer Metalogics. Justin and I joke. I guess we were the first sucker. And by the way, these relationships, right? In order for them to work, you have to invest, right? The software developer has some idea of the use case, but they don't really understand it the way we do, right? And that's actually one of the reason I actually picked Homecare Homebase is because they were a customer, right? So I felt like there would be less lost in translation because they were eating their own dog food. So I don't know if that answers the question, but we're just sort of wired to 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 think there's a better way out there, and we better find it sooner than others.
For sure, for sure. That's awesome. So this is the last visit first podcast, and I created it because I want the first visit to be just like the last visit. And so can you tell me about a patient or an experience, or, I mean, it sounds like you ran into the owners of the company on a marathon, which I didn't even know you ran marathons. That's crazy. I guess as a
I
rower,
used
it
to.
probably
I
makes
used
sense.
to. I used to. Now I walk. Now I walk.
But as
It turns out you burn the same amount of calories whether you run 10 miles or
uh,
walk 10 miles. The only variable is time.
that's right. That's time, right? How much time can you spend doing it? Tell me about that one patient or that one, that one scenario that really touches you that you think about a lot.
Well, so I'll try to make this brief, but my first son, Christian, is 16 today. And he was born at 26 weeks, we think. You never really know for sure. He was in a NICU for 277 days. He was on a ventilator and feeding tube for 2.5 years. He weighed 646 grams when he was born. He was a $3 million baby. Right. So and then basically after 9 months in the NICU, we brought the NICU home, and I had home care for the first time. Right. A nurse came to our house every night for the night shift to watch Christian on the ventilator, because if there's a problem with the baby on the vent, like Christian can say, "Hey, I got a problem here with a trach plug or whatever, or my humidity is not right." The nurse has got to watch. And so I I'd actually had never done a home health visit, and so we had Christian about 5 years after I bought residential. I'd never done a home health visit till the nurse showed up at my house to take care of my firstborn son.
Wow.
And it was through that I got to sort of live our service, uh, walking on the feet of a caregiver and a parent, right? And that we built some great relationships with our nurses, and I threw some nurses out on the rear, like, "Why are you showing up here smelling like an ashtray when my son's on a ventilator?" And so I just learned that no matter where you are, you need great advocacy, right, as a patient today, right? And then I just know as an advocate, like, I needed to be able to call somebody to tell them I got a problem. In most healthcare organizations, it's hard to get to somebody who can make a difference. My father-in-law's in the hospital in the ICU right now, right? And if you don't advocate with what's next and why isn't that happening, and what are you guys thinking about addressing these deficits? the patients will just sit there, right? And so I just think a lot about Christian and how we need to show up at the home, right, knowing what's going on with a great team that's totally focused on that patient. And so, I don't get to do that, but it's my job to equip our team so they can do that as best they can.
Yeah, I was thinking about it, like you're just thinking around medication management or the basic things. I mean, a nurse, went to school usually a long time ago. They had 2 classes of pharmacology and now they're in the home. And when they were in the ICU or the hospital and all that, they had a doctor, a pharmacist, all those people around them. And now these angels that we have in home health that are taking care of our patients. I mean, they're doing everything. They're the
Yeah,
supply manager, they're the med manager, they're the
no
wound
doubt.
care manager. They're taking vital signs, they're doing physical assessment, they're supporting the family, they're dealing
Yeah,
with the family. And so the job I think, is way harder. And it's in a mobile
yes,
workforce, right? You're in a car driving to someone's house, which could be an uncomfortable situation.
yes.
Not everybody wants people in their home, and so I call them angels because I think they're doing a really, really, really amazing
No,
thing.
yeah. You remember that TV show MacGyver? I feel
I
like
do.
they're all MacGyvers, right?
They
Where
are.
they got to show up and they gotta work with what's there, right? It's not like a sterile, totally stocked, hospital unit. They got to work with what's there, and then they've also got to be chameleons where they can deal with challenging family members, some rabid dog, right? Maybe a less than totally safe neighborhood. Like our field clinicians, are their strength, right, and their courage, right, to care for patients is remarkable. But the other thing that I think about too, and is look, we're only there for a limited amount of time, right? As the home health provider, as the hospice nurse, right? And then ultimately, it's our job to equip the family and the patient so they can take care of themselves. And that's, like when I could, when my wife Dana and I could change Christian's trach and handle his feeding tube when the pump broke down at night, like that was great. I felt much better than having to call somebody to tell me how to do it. And so that's the other thing I think about is how do we really equip the family and the patient so they're almost as good as when we're there. And because that's just the reality. We're not there that much. And we can show up and be helpful and be loving and be resourceful, but ultimately we leave and then they've got to fend for themselves. And that's another thing I guess as I think about visits and try to put myself in the shoes of our patients, that's what I want to get better at.
Is educating the patient and educating
Yeah,
the family.
empowering them to have the confidence to take care of the situation as if we were there. Now, look, there's going to be certain things wound care you, and I also agree with you that the role of the case manager in the field is overwhelming at times, right? Just all the plates they've got to spin. And so one of the things we've tried to do is free up the clinical supervisor so they're able to spend more of their time supporting the field staff. Then we're also saying to ourselves at a very granular level, what's the work that the field staff's doing that somebody else can do? And getting somewhat dogmatic about that, like so that they're not bogged down with things that someone else can do. And actually, I think back to your question about AI, I think AI can help with some of that. And back to my other point about being a good leader means you got to really know what's going on at a granular level. That's what this is what I'm talking about. Do you really understand what's on the plate of a case manager on a day-to-day basis, and can you then parse out the pieces of it that maybe we could delegate to somebody else, and then how could technology play a role there? Like that's to me where the magic happens, and that's what I like about my job, right? It's solving those problems.
Yeah, when I worked for April back in the years, we used to say there's 2,000 problems in home care, and we got to solve each one of them and make sure they never come back. And then how do we continue to solve them? Yeah, with AI and the visit documentation, and I've been doing a bunch of work and analysis on all these companies out there. Is I'm in the AI space a lot, and I think we have to figure out how to get a starter care visit to be less than 2 hours. And I always say that our goal should be, how do I get a nurse to want to do a starter care visit? Today, they have to do them.
Yes.
It's the most scrutinized visit. It's the one that Medicare is going to look at. It's the one we get paid on. It's the one everybody reviews. It's like turning your paper in and letting the whole classroom, grade your paper in a different way.
Yeah.
And so how do we make that easier, faster, better so that they want to do them versus have to do them? And that should be our goal. I mean, that's
Yeah.
the easy goal. And if we solve that, then now everybody's going to want to come into home care. And it's definitely or home health and hospice. It's definitely the area that I'm spending a lot of my time on. It's awesome. I
Well,
appreciate you
and
talking about
hopefully, Yeah, no, no, that's right, Tom. And I think home health agencies get in trouble when they misassess the patient, right? Right. We never get in trouble for our interventions. It's just when those interventions don't align with how we say the patient is doing. And I think because of all the challenges with documentation today and just all that's burdensome about, Oasis and how it's changing all the time, right? If I could sort of wave a magic wand, the one thing I would want to fix is a better assessment, a more accurate assessment, right? Because if I have an accurate assessment, right, then it's easier. Then everything else after that gets easy. And I just think, do we really every time do we really get these patients to demonstrate right what Oasis is trying to assess, or are we interviewing, right? And that's what I want to see as a part of offloading the work is a better assessment.
Yeah, when we talk a lot about in our Oasis assessment. Nana just got out of the hospital. We call them Nanas because I had a Nana instead of patients. So Nana just got out of the hospital. She's fully hydrated. She's fully medicated. She's had a low sodium diet for the last 6 days in the hospital, and she's so happy to have her remote control and her dog and her family around her. And so she's when you're doing that first assessment, she's at her best.
Yeah.
Right. She's just got out of the hospital. She's excited. And then we wait 4 or 5 more days. Papa's not cooking a good sodium diet. She's dehydrated now. The medications are making her dizzy. She's frustrated. The family's gone. And now she's there by herself. And at that time, when we reassess that patient or go back out for the second or third or fourth visit, now we see Nana at her worst. And then
Yes,
we
that's
continue
right.
to go down that process. So I'm with you on the Oasis. The Oasis data set is a great data collection set. It's also very time consuming.
Yeah.
If you said doctors, you guys all got to do an Oasis data set, they'd all quit. If you made the nurses in the hospital do it, they would never get to any patients. All we'd be doing is sit in the ER in lines. But in home health, we've over scrutinized that, and it's a real challenge for us.
Which is why, I would say one of the things that from the jump we always did is we always employed our own therapists, PTOT speech, right? We didn't
Sure.
contract, right? Because I want them on our team and fully on our team and solely on our team, and right because the nurse goes out and then I want to get that therapist out there quickly, right? PTOT speech, right? If you have a stroke, that speech therapist shouldn't wait 2 weeks, right? But Nana or my father-in-law, who just spent 2 weeks in a hospital and a week at a rehab facility, he couldn't wait to get home and sit. Okay, and that was like the worst thing for him. And so, yes, the nurse comes out, but then we got to get the PT out there to get him going, right? To do the as the doctors used to say with Christian pulmonary toileting, right? So that they're not stagnant, right? And they don't, have fluid buildup and they don't have exacerbation of CHF. And I think I agree with you. We're assessing them at the at the best they've been in a while. But then if therapy can get out there timely, which is something that's sort of core to our playbook, right? Then we can get them going on a home exercise plan, hopefully, and we can give them goals and motivation, right, to not just sit.
And the worst thing you can do is be stagnant and not move.
Yeah,
Be
no,
bed
that's right.
bound.
I'm sitting down right now, like I'm only doing this for this, right? Normally, I'm standing up, walking around, but I don't want to make anyone who's listening to this dizzy.
I'm the same way. And for me to sit still for an hour is really tough. Let's talk about quality and outcomes. So how do we measure it in this industry? How do you make sure you're the best? What are you doing that's changing the outcomes of your
Yeah.
organization?
So I try to keep it simple, because of all this risk adjustment, I still don't understand 20 years later. So the outcomes I care about is, can I accept the patient, right? My friend David Bayado told me the first outcome that we measure is, yes, I said yes to the referral. Okay, so can I accept and I'm like, you know what? That seems like an easy one to measure. So can I take the patient? And then can I open them timely? Can I get out there quickly? All right, and not just with the nurse, but with what they really need that was on the request for eval, right? All the disciplines, timely. Um, and so we measure that, and we've done a nice job and sort of getting out there within 48 hours. I won't get into all the specifics, but I think we hustle to the door, right? Because that's not only important clinically, and from an outcome perspective, many times we're all in a jump ball for these referrals now, the way they're managed through these portals. So can I take the referral? Can I get out there quickly? When they call us, do we get back to them timely? And we're using our own tool called Claris to make sure that every phone call that comes into the branch is recorded, it's transcribed, and is routed. And I can tell if we followed up on those calls in real time. And then the thing I guess as I care about, Tom, is hospitalizations, right? And so hospitalizations, another thing that's easy to measure, they either went to the hospital or they didn't. Um, and we're always trying to figure that piece out. But I think that where we're unique is how we try to leverage hospice, right? Because look, we're order takers in home health, right? I don't get to write the order. I'm just do what I'm told. And that requires an engaged physician, right? Which, and physicians, there's another podcast on that, but so what can I control? Like I feel like as the home health provider, I've got to follow the orders, but if I can get them to palliative or hospice where they can get more support and where hospitalizations actually is maybe off the table, well, that's another big piece of what we do. And obviously Metalogics has been helpful in that, but I would say, software wires the business, but it's not, but you still need a culture, right, to embrace the process. And so those are the outcomes for me. It's accepting the referral, getting out there quickly, being available and responsive, which is why every patient gets my personal cell phone number on home health, and then thinking about how we can best support them, which is oftentimes for those that are likely to be hospitalized on hospice.
It's amazing when I look at the stats and when I put my Maxwell Tech hat on and I look at the stats, 48 hours is great in home health. There's stats out there where people are waiting 5 days. I always think about your father-in-law just got out of the hospital and he's now at home and they've ordered home health and now it's 5 days before someone shows up. There's a lot of bad things that are going to happen.
I think and this is for all reasons, right? Which includes patient deferrals, right? But I think we're about 80% out in 48 hours. And that's improved quite a bit just through some of the innovation we've done around technology and process.
It's awesome. And discipline, right? And culture, right? It's like our culture is we want to be there first.
Yeah. And look, it's harder and harder to get a complete referral. And you've got to have a great sales team who sees themselves as part of the intake process, not just making the intake fax ring. And that's a big part of our culture. Like we look at conversion rates and timeliness of admission by sales rep. And we're always trying to spin the knobs to create alignment and incentives so we all care about the same outcome.
That's awesome. That's really awesome. Let's talk about the future of home care and hospice, or home health and hospice. What do you think the future looks like? Open up 3 to 5 years.
Yeah. Well, 20 years ago, right, home health and hospice was sort of in the shadows, right? And then, we had to live through, all the heat task force and just all the abuses, right? Amedisys made headlines, right, for 14 visits on ortho patients, no matter what, right? And like I think now that we're fully capitated, I feel like it's all that risk is off the table, and all that criticism is off the table. Where whether I do 5 therapy visits or 15 therapy visits, I get paid the same, right, based on these clinical groups. So I really like PDGM and how it's, I think, taking a lot of the criticism away of home health. When we were, the more therapy you did, the more revenue you got. Like I like that. That's where we've landed, and so it's not as easy to sort of criticize us. And so I just see, we work a lot with health systems, right? And some of them are tied to large payers, and they like home is the heart of their strategy as a health system. Care at home is part of their strategy, and I just think more and more care is going to the home. Right. We 5-6 years ago, we bought a home infusion business that's actually now our biggest business and bigger than home health and hospice. And this is all about immunoglobulin replacement therapy. So plasma-derived therapies for patients with rare chronic conditions, treating them at home. And I just think more and more care is going to the home. I don't think Medicare is going to ever pay us what we think is fair. God bless everyone who goes and lobbies on those fronts. I think we have to do that, but I'm not sitting here waiting around for people to get my reimbursement right. Like we've got to go grow through it, and we've got to get more efficient without watering down the soup in terms of the care offering that we provide. And actually, I enjoy that challenge, right? Where we're sort of reimbursements fixed, now solve it. And I do see health systems, payers really starting to value their home health and hospice provider networks. They are listening to us. I think COVID was a pivotal point there. I remember being on a call on a Saturday afternoon with Seema Verna, who was the CMS administrator at the time, in the middle of COVID, and she's like, "What do you guys need?" Now, I don't know how much of that she ever did, but I think COVID was a real pivot for the continuum waking up to how home health and hospice can help. And it's not like anything radically changed. We've always been doing what we've been doing, but now people are starting to appreciate it, particularly as the cost of healthcare rises as people run out of inpatient places to put people. What about you, Tom? Like 10 years from now, I guess I hope we'll finally have Homecare Homebase interoperability, like the rest of the world, right? And I love Luke, right? I love Luke and that team, but come on, you know.
That's
Um,
funny. Yeah, I think, technologies are going to have to connect more together. I think that's going to be important. You shouldn't have to go to hospital to CarePort or Epic to CarePort to, via fax to into your home care home base and rekey. And I mean, I always talk about, just if you take yourself to if you have a hospitalization of any kind, you go to your doctor, you give them all your information, your name, address, phone number, meds, allergies, all that stuff. And then you go to the next, you go over to get a CT scan, and all of a sudden you're doing the same thing. And then you go over to to the lab, and now you got to do the same thing. Like, why is that all not connected? And it's just a waste of time and money and effort. And that money is people that are having to input this into multiple systems. And especially if you're jumping from, Epic to Homecare Homebase to others. And so interoperability is going to be a big piece. The real challenge of the interoperability is, compliance and consent and all that stuff.
yeah,
We could solve that. I mean, the banks have solved it. What if you had to do that at your bank, and each time you went to the bank, you had to give them your account number and your routing number and all that? It would be disastrous. So the banks have solved it, and we should be able to solve it.
I guess I wouldn't be surprised, and it's probably be 10 years from now if there's a bit more of a unified post-acute payment as well. I mean, I can remember at a Homecare Homebase conference maybe 10 years ago, April talked about that for the first time. We're nowhere closer to it than I think when she first talked about it. But I can see 10 years from now, just with the insolvency of Medicare, okay, which we all need to wake up to. Just wanting to force more her collaboration across subacute, outpatient therapy, home health, hospice. I can see them trying to drive a more unified payment.
Sure. And I think we're seeing that a lot in the Medicare Advantage world now too. And I mean, you're a guy that does joint ventures with hospitals, which that I've always found very interesting. And in that joint venture, you have to take a lot of the payers that other home health agencies may not take.
Yes.
How has that impacted your business? How has that impacted what you do and how you think about the care in the home?
Well, so it's interesting. We also are with one of our joint ventures. We were one of the first. We partnered with Contessa, right, in one of our joint ventures out of COVID, where we did hospital at home, right, and sniff at home. And we don't really make any money on that, but we do that as a service to our joint venture partner, right, because they needed our nursing resources and our therapy resources to sort of fulfill that service offering.
Hey, define that for people, David. What's the difference between hospital at home and sniff at home versus home health?
So one, I'm being paid by a Medicare Advantage plan versus traditional Medicare, right? And it's not episodic. I'm basically, as the home health agency, a subcontractor to the hospital at home provider, and they're paying me, per visit or per hour. And it's much different than the episodic payment and much less. But we do that because our health system partner is trying to figure out this hospital at home model, and no one's figured it out yet. No one's doing hospital at home at scale. It's all very nichey, and it's hard to get hospitalists to sign up for it. It's hard to get patients who just left home to come to an inpatient setting to get care, to be told, what? Turns out the best place to care for you is where you just came from. Like, that's not an easy thing to convince an 85-year-old of. So I kind of lost track of the question there, Tom.
Yeah, I was just making sure we explained the difference between sniff at home and
Yeah.
hospital at home and
Yeah.
home health.
Yeah.
So the reimbursement model is different. They don't have to
Yep.
do an OASIS on those
No,
patients.
actually, the documentation's a whole lot less, which is nice. It's a 24/7 service, right? Versus us as being more 9 to 5. And there's no sales involved. There's the intake process is radically simplified.
Are the patients that much sicker?
No.
That's the
No.
interesting one. That's what I've always heard. And the patients are about the same sickness. It's just
Correct.
the model that they signed up for are completely different. Why do you think that Medicare Advantage is becoming so popular in home health? I mean, back in the day when we started working together in 2005, we were all 95% Medicare and 5% non-Medicare. Why do you think that's changed? Is it the joint ventures that have changed it, or is it the patient population, or the silver tsunami?
Yeah, well, I think they've done a good job marketing. I think the Medicare Advantage plans have done a good job marketing to Medicare beneficiaries. But look, I would say we've made some real progress with some Medicare Advantage plans, getting them to support our reimbursement, not to the full level of traditional Medicare, but pretty close. Episodic payments, no authorizations, some upside. I mean, for the most part, we're still fee for service, although it's capitated. We're not doing any risk sharing of any consequence, but we've been able to, in part because we have a health system attached to us, but also because we're a larger provider in many markets, we've been able to get them to take their rates up from $150 a visit to 90% episodic. And that's been in the last couple of years, and that's been refreshing. And I think it's all because they see us as a more cost-effective, patient-preferred alternative. They're finally getting it.
And is that because we've been talking about it more, improving ourselves with data, or is it just, because everybody's starting, across the board, the whole industry's changed.
I'm not sure our data's gotten any better. I'm not sure our clinical outcomes have gotten any better. I just think their appreciation for what we've done all along has gotten better, and they as the payer. And I'm sure behind the scenes they're running all the math that says, hey, if I spend a little more money on home health, maybe I can reduce my need for. Look, we worked with some of the first bundles 10, 15 years ago with our health system partner in the Midwest, and we were able to significantly reduce SNF length of stay, by getting in there and getting them to home health quicker. So I think there's just saying getting them to home health quicker, whether it's getting them out of the hospital quicker or getting them out of a SNF rehab facility quicker, there's a real ROI there versus paying us 90% of PDGM.
And it's where the patient wants to be. It saves the industry money, or saves the taxpayer money, and the patient wants to be at home. Like I want my remote control, my dog, my house, my chair, my recliner.
Yeah. And I guess back to the silver tsunami, like there just aren't enough SNF beds and hospital beds. So they're all playing the length of stay game.
Yeah. And it's also interesting to me as I study this a lot, and I see this at my gym in Minnesota. They have a silver sneaker program. So if you're on a particular Medicare Advantage plan and you're on the silver sneaker program, you get a free gym membership.
Yeah. See,
traditional Medicare doesn't give you any of that, right?
No, that's right. It's not hard to market better than the government, right? So.
Well, we don't want people coming after us on the podcast, so we're not going to bash on the government.
We love them. Look, the hospice benefit, the hospice benefit is perhaps one of the most amazing benefits provided for by our government, right? After the military and after maybe, the postal service, right, which is becoming less, like the hospice benefit is incredible, that all that is provided for, right? No copay, no out of pocket, 13 months later, bereavement support, chaplaincy. It's social work. It's an incredibly rich, needed benefit. That's just another part of our mission, right? Is to get hospice to our patients, right? I alluded to it earlier because it is in many ways, I think, the silver bullet for what we're trying to solve for in home health and what patients want. Your listeners know the stats, right? They're just around what hospice does at end of life versus the ICU alternative.
It's true. Hey, let's take a quick pause real quick to thank our sponsors.
Hi, I'm Jennifer Maxwell, co-founder and CEO of Maxwell Tech. In care at home, smarter care starts with smarter data, and that's what we at Maxwell Tech deliver with our data and analytics services. By turning EMR data into tailored insights, executive dashboards, Maxwell Tech's analytics can help you monitor financial performance, improve patient care, and boost operational efficiencies. By helping your organization move forward from raw numbers to true strategies that truly matter, Maxwell Tech gives your team the confidence to act in a fast-changing healthcare environment. Discover how Maxwell Tech's analytics services help care teams make confident, impactful decisions. You can find us at maxwelltech.com or directly sales@maxwelltech.com.
This episode is also brought to you by Steno Health. Steno builds enterprise software for home health and hospice agencies designed to ease one of the biggest pain points in care, documentation. The platform listens in the background during visits and transforms conversations into structured notes with built-in quality and compliance checks. Steno is developed by clinicians, for clinicians, with a focus on ethical and compliant use of AI. The goal isn't just faster paperwork, but cleaner data and more time for what matters most, caring for patients. To gain more information, visit stenohealth.com. We would like to also thank our episode sponsor, Levo, the company transforming how home health and hospice providers recruit and retain their teams. In just under 2 years, Levo has expanded to serve some of the largest providers in the industry, helping them increase capacity with 24/7 recruitment support and tools that risk stratify employee issues before they lead to preventable turnover. Their customers have seen time to fill drop by as much as 40% and retention improved by as much as 20% in just 6 months. Learn more at hellolevo.com. Couple other questions. Talk to me about how you recruit and retain employees. What's the secret sauce there? You're doing a great job around out recruiting everybody.
I don't know about that, but it's always been core to our business. We've always we've been somewhat maniacal about, okay, let's really drill down on the candidate experience. Is that something I'd want to do, or is it appropriate to ask them to fill out like a 20-page questionnaire just to apply? Right. We were actually the first company to integrate Workday with Indeed. We integrated Workday with Indeed before Workday did. We've just always recruited, and we've always tried to differentiate how we've recruited. Recruiting today is much more digital than it was 20 years ago. One some of my favorite recruiting highlights were, God rest his soul, I hired Chuck Woolery from The Dating Game 20 years ago. I invited every single nurse in Wayne County, right, which is the county that Detroit's in. We sent out 30,000 postcards, invited them to an event at the Fox Theater, which is this old theater in downtown Detroit, across from where the Tigers play. And Chuck Woolery gave away a lease car for a year. We invited 30,000 nurses, and they pulled up, and we treated them like we had paparazzi there to take their picture, and we had the best time. We probably spent at least $100,000 on this event 15, 20 years ago. And Chuck Woolery masterfully flirted with all the female nurses and gave away a car and kept the suspense going till the end. And we didn't hire a single nurse from it, but we had a great time. And then the other thing I used to do was I said how we always were trying to recruit these physical therapists, and in Detroit, a lot of them were Indian and were vegan. But I had this great idea of we're gonna recruit all these PTs, treat them like no one else is, and invite them to the Capitol Grill for kind of like you would do for a pharmaceutical dinner. I would invite physical therapists to the Capitol Grill, get a private room, and they get the steak menu. We'll have the tofu. But I think we've just always tried to make sure we have enough open positions. Another sort of tactical thing here is that people underestimate attrition, so they don't open up enough positions. We don't outsource recruiting; we do it all ourselves. We've always tried to say to us, I want to hire enough nurses until they're twiddling their thumbs, and when we have nurses twiddling our thumbs, we'll stop. And we've never gotten there.
And then you're hiring salespeople to go fill the backside of that too.
Yeah, that's right. I mean, and that's the challenge in this business, right? Is managing that equilibrium of supply and demand. There were times early on when, Joe Mooney was my business partner and I had more referrals than I had nurses. I'm like, Joe, you need to go home and sit on the couch for a week and I'll call you. I can remember some of the first Thanksgivings back at residential days in Detroit where, I had 20 opens for Thanksgiving. And it's like, well, let's make a deal here. How are we going to get these nurses to go open these 20 starts of care? But as we've gotten bigger, I think we've gotten a lot better at trying to build capacity ahead of demand. It's still a challenge, right? But and that's one of the things I've loved about the business side of this business is that demand has always outpaced supply.
And I think it's going to continue to do that. I mean, they call it the silver tsunami. I'm not sure I'm a big fan of that, but 10,000 people are turning 65. People are living longer. They're going to live older. AI is going to help that. I think AI is actually going to increase lives. They're going to be able to early diagnose different kind of cancers or tumors or those kind of things. And we'll be able to treat them sooner. So people are going to live longer, which means they need more care. You spend all your care dollars most people spend all their care dollars in the last 2 years of their life. But if their last 2 years is 90 to 95 versus 78 or 80, then we're going to spend more money on them. So I am worried about the Medicare benefit and can the government solve that? And the other problem we have is every 4 years, there's a complete, exchange, or most of the time there's an exchange of the entire CMS staff as well as HHS staff. And they come in with different agendas. We have Dr. Oz now, who's a surgeon that we had, prior to that, we didn't have a surgeon. We had a doctor who was more into the preventive medicine. And so that's going to change how we do business. And I think the interesting thing in this business is we just have to become flexible, right? And when I was in the military, I was a Navy corpsman, and we used to call it Semper Gumby. I mean, instead of Semper Fi for the Marines, it was Semper Gumby. We're always flexible because you have to be constantly flexible. You never know where you're going, when you're going, what you're going to be doing. And I think that's interesting. it's amazing to me as we've seen the industry change and evolve and consolidate, but these companies are getting bigger and bigger and bigger. I mean, 20 years ago, residential was a really small home health agency. Now you're one of the biggest in the country. And so you've had to evolve, you've had to grow, you've done acquisitions, you've acquired people. And I think it's that's what it's become. It's you have to be flexible. You have to be willing to change. You have to be willing to look around the corner and figure it out where someone else can't.
I agree. We haven't done a lot of acquisitions, and the acquisitions we have done have been small because I've just always felt like I could just go recruit that business. I don't have to pay for it. Now we have most of the acquisitions we've done is buying the home health and hospice service lines of health systems that we then partner with. But I just, and we get back to sort of our leadership team. We've been together for so long that, and there's been a lot of turnover in our industry. Obviously, the Optums acquiring LHC and Amedisys is some of the headlines, but there's been a lot of consolidation in our industry. One of the things that I think makes Graham, healthcare and our home health and hospice business unique is Graham's not going to sell this business. And I think when ownerships change, when you have an ownership change, that generally leads to a leadership change. And when you have a leadership change, that's when everything kind of tips over. And, when policies start changing and just the relationships between the frontline staff and the branch team, I don't need to name names, right? But there's ownership stability and continuity is, I think, a core to our strategy, right? We're not selling our business. And by the way, we have no debt. And so we're not under the gun, right, to pay anyone back. And so if Medicare takes reimbursement down by 20%, we'll feel that pain later than others. And I think that, back to your question early on about getting people to stay, I think being part of the Graham, right, where Warren Buffett was on the board for 40 years, and it's this long-term buy and hold, right? I mean, lots of people would love to buy our business, right? You look at our dots on the map in Michigan, Illinois, and Pennsylvania, it's where the strategics are not. Like, we've held them off for 20 years, where we'd be totally accretive. But we're not up for that. We're up for just continuing to build a great business. Catherine Graham was known for her line, quality and profitability go hand in hand. And anyhow, I'm rambling a bit, but I think that's another part of our secret sauce is ownership stability leading to leadership stability. I mean, I think that's what has made Beata so good, right, over the years,
Sure.
Right? Private equity has been good, right, I think, to improve some of what we've done, but all the ownership turnover has, there's a cost to that too.
I agree with that. That's, we see it all the time in different, businesses we work in is when, you start having leadership changes, people start, benefits start changing, PDO changes, all those kind of things start changing. And then all of a sudden they're spending more time, talking about all that than they are doing caring for patients.
Amen.
And it makes it tougher. So
yeah.
Couple more questions. And then I'll let you ask any question you want of me too. But, what do you want your legacy to be when you're done in home health and hospice? What do you want to be known for? Who's David Curvis? And I mean, you mentioned Warren Buffett's name, which I think is awesome. And Warren's, I read all of his books. I've followed him for years. He's one of the greatest investors in the world. The guy's made more money than anybody. He still lives in a little bitty small house, and he's got the greatest story. So we know his legacy. What's your legacy?
So, well, quickly on Warren Buffett. So I took, we homeschool our kids, Dan and I took my 14-year-old son to the Berkshire Hathaway meeting this past May in Omaha. And we got there on Thursday and we went to Go Rats, which is Warren's steak place. And we split a big steak. And then we drove by Warren's house. And then we were in the room when he announced after 60 years, he was retiring as CEO. And he's just amazing how he's 94 years old. Like, Lord willing, I get to work till I'm 94 years old that way. And because that's what I'd love to do. But it was interesting. So he announced after 60 years, he's retiring as a CEO. And Tim Cook was there and a lot of dignitaries were there. Hillary Clinton was there. 20,000 people stood up and gave him a standing ovation, right? And like several minutes, everyone sits down and Warren dryly responded, "Well, there's two ways to take that applause, but I'll take it either way." Right? Like, but I think this is public. This is public. I'm leaving Graham Residential at the end of this year. December 31st will be my last day. It'll be 20 and a half years. So walking in that office door on 8 Mile 20 and a half years ago, I definitely feel like I've stuck around long enough and built something with the team. But I just think my legacy is that there's a business that will carry on, and hopefully will be growth oriented and service minded and excellent and seeking excellence in all we do. I just hope folks will think back to the 20 years I worked with them and just be grateful for what we accomplished together. And I think the thing I'm probably most proud of is all the folks who started out at this level and are now basically helping run the business. I mean, across our business, the number of folks who were promoted from within, that's the most gratifying to me, right? Is, taking a nurse and making them a supervisor, or taking a sales rep and making them somebody who's running a market. Well, there's stories like that all across our company, right? And I think that's what's most rewarding, is that we grew and the team grew with us, and we all shared in that success. That's what I hope people think about.
Yeah, and if you think about the lives that you touched in that model, I mean, the number of kids that have got their college paid for, or been able to
Oh
go
yeah.
to school, or their, families have been able to take a vacation because you gave somebody an opportunity to get promoted and continue to make more money and make more success for themselves. That's kind of fun. And then you also have, I don't know how many hundreds of thousands of patients you took care of over the last, 20 and a half years, but
Yeah, I know.
somehow you influence the touch of, millions of patients, and that's pretty amazing.
No, it's interesting, that I mentioned that phone number. I get 3 thank yous or maybe 4 thank yous to every one complaint, right? And that's what's amazing also about home health and hospice. I mean, it's very rare that I call a service provider and be like, "Hey, you did a great job." I just move on to the next thing in my life. But the number of people who, or in hospice, they send us a check and like we didn't even ask for, right? That's what's remarkable about the impact that we can have, right? Being in the home, being, holding someone's hand literally and figuratively, giving them hope and confidence and a path forward. That's what I'm going to miss about home health and hospice, is just how people appreciate so much of what we do that they actually take the time to call a stranger and say thank you.
We should all learn from that, though. We should take
No, you're right.
a lesson from that. That's
Yeah.
amazing, and it's fun to get those. And it's amazing how many home health aides in the industry get letters. I mean, it's totally bizarre.
No, there's a couple. Back to Christian, right? There's several of the nurses who you know slept at our house or worked at our house when we were sleeping. Like, they're still on our Christmas card list 16 years later, right?
That's
So some of
amazing.
those relationships are those are real. When you're having to help a family member like that, who's really sick, and you get them better, right? There's a lot to that. And even also, I mean, on the hospice side, right? When we're there, when a loved one passes, it's cliche, but we become part of that family. And I always say, like, that is the special opportunity that we have, right? And that's the unique. And back to your last visit first, I often say, as it relates to home health, when we admit a patient, we throw a wedding, figuratively speaking, like all that we do. And then we discharge a patient, it's like we're breaking up with them, like our 6th grade girlfriend. Like, we just stop calling.
Right.
And I think there's an opportunity there, and I know you have some solutions around that. We talked about that yesterday. So we don't break up with them like our 6th grade girlfriend, and we stay connected to them longitudinally, because they're going to need us again, right? 40% of all patients on our census today were previously on our census, right? And I would say that's another thing that we try to do, and another, I would say, angle for growth, is recognizing that today's patient is going to come back, as it relates to home health.
Yeah, that's true. I mean, and we only get one chance to do it right in hospice. So I always say that, there's only one chance to do this right. And if you do it wrong, it's going to be very impactful. But if you do it really right, it's going to change the lives of many, many, many people. And
Amen.
then in the Reach product, where we're, continuing to stay engaged with patients, is so important because
Yeah.
they're coming back. And if they're not coming back to home health, at some point, they're going to need hospice. And hospice is the greatest benefit, like you said, that the government's ever produced. I think it's better than the post office. Maybe not as good as the government and the military. I was a military guy, so I'm very tender to that. But I mean, it's the greatest benefit in healthcare, because we pay for everything, and we provide more care, and we're caring for more than just your health. We're caring for your spiritual health, or your social work, or helping your family, and it's we help with the grieving process, the bereavement process. So it's pretty amazing. David, any questions you have for me?
No, I don't have any questions, but I guess I was just thinking about our relationship for 2 decades, and just how grateful I am to know you as a colleague and a friend, and a trusted advisor. And I just want to acknowledge, Tom, you and your wife Jennifer and your team. Just, you did a great job pivoting out of Homecare Homebase, right? And I think you're playing an essential role in our industry today, right? And I think people really look to you, right, sitting in sort of the catbird seat, as somebody who is obviously trying to run a business, but also you're really trying to help, sort of the greater cause of our industry. And I just think I'm glad you didn't retire, right? And I'm glad you're continuing to plug along and to help us innovate through technology and services. And I'm just thankful that you're in that seat. God put you in your role. I believe,
Listen to
and you are uniquely qualified, right, to help our industry. I guess on behalf of our industry, and certainly, you know, the success that I've been a part of for the last 20 years, I wanted to say thank you to you. You've done an outstanding job helping us all run better, but also think ahead, right, for what we can do next. And I think you're going to continue to do that, and we'll all benefit from it.
Oh, thanks, David. That's really nice to say. And it's true. It is a calling for me to do this job. And I mean, I don't know if everybody knows the story. I did retire from Homecare Homebase and thought I was going to retire forever. And what you find really quickly, I was 46 years old and said, I'm done. The guys you play golf with on Tuesday afternoons, Wednesday afternoons are all, your patients essentially. And
Yeah.
they're fun, but you can only listen to the same story, over and over and over about how they made a double eagle in 1985 on this hole. And I'm like, okay,
Yeah.
I've heard that before. And so it was something we weren't really, Jen and I decided to really get after it. And this podcast, I mean, last thing I want to do is a podcast. It takes a lot of time. I had to hire a producer, equipment, all this stuff. And I'm like, I don't want to do this, but so many people in the industry have said, Tom, you need to do it. You can get all the right people on the screen. You can tell the right stories.
Yes. And there are stories to be told, right? I've actually started this new habit. I'm walking about 10 miles a day. Right. So it's 20,000 steps. It takes me about 3 hours. And I'd say half the time of that time now I'm on phone calls. The other half of the time I'm trying to educate myself. And I do it through podcasts. I listened to a Christian podcast this morning. I just came back Monday and Tuesday. I was at the All In Podcast Summit in Los Angeles for 2 days because I've become
So
a fan
cool.
of that. I listened to the Founders podcast and these longer formats, right? To tell the story of an industry or of a company or of an idea, I think this is going to bear fruit too. And I'm happy to be the leadoff hitter. And the good thing is I know there's going to be a lot of people behind me hitting cleanup doing a much better job, but I was happy to be the first one.
Yeah. And I'm very honored that you were the first one. And thank you for agreeing to do this. And
for sure.
Always a good time. I hope our friendship remains forever as you change your gig. And I'm sure we'll find something to work on together in the near future.
For sure.
For sure.
All right, brother.
All right. Please say hi to Dana and the rest of your family for me. And look forward to seeing you guys soon in Nashville.
Okay. Indeed. Thanks, Tom.
All right. Thank you.
Bye.
Bye-bye. Yeah. So thank you everybody for watching the episode. I'm Tom Maxwell again. Super excited that you followed the Last Visit First podcast. Please share this with your friends and family. Anybody in the industry out there, we want to grow the message. We want people to hear what we're saying. Special thanks to our sponsors today, Maxwell Tech, Steno Health, and Levo. You can find their notes in the podcast. You can get access to their web addresses. Go look them up. They're cool companies. They've all done a lot of really impactful stuff in the industry. And then special thanks to our producer, Cole Sorensen. He's done a lot of work to get here. So we've been working on this for about 3 or 4 months, and we're super excited about where we're going. We're super excited about all the people that are following this podcast and that have reached out to me to be on it. We'll do one every 2 weeks. So every 2 weeks, we'll release a podcast for you. If you want to be part of the show, let us know that too. If you want to sponsor the show, of course, you can reach out to Cole Sorensen at lastvisitfirst.com. He'll put a link to the show notes as well to his email. And if there's any comments that we want, if things we could do better, things that we shouldn't say, do more of, do less of, we want to hear all of that. So it's really important to me to get advice from the industry. Please let us know what you feel, what you want to see more of. If you liked it, we'd love that. Please share it. If you have areas you'd like for us to talk about more in detail, I want to know every one of those. So thank you again, and I'm very humbled and blessed to have had David Curtis on this show, and I think you'll be really amazed at the rest of the guests that we're having. Thank you.